Karim. Is my voice clear?
Yeah, it's very clear. Welcome, Thomas.
Oh, hey, how are you? It's nice to see you.
I'm good. Just wait for a couple of seconds.
Je peux commencer, c'est bon?
Je crois que tu peux y aller. Hein.
C'est bon? Alors, je pense qu'on est de nouveau connectés tous ensemble. Donc, bonjour à tous. On va continuer le programme et on va ouvrir cette nouvelle session qui est une session vessie que j'ai le plaisir de modérer avec Yves Allory, qui est anatomopathologiste à Curie. On a vu que le paysage thérapeutique a récemment beaucoup évolué dans les carcinomes urothéliaux, notamment au stade métastatique avec l'arrivée des immunothérapies en deuxième ligne et désormais en maintenance, et beaucoup d'essais cliniques en première ligne et également dans les cancers localisés en situation périopératoire avec soit des immunothérapies, soit des combinaisons de chimio et immunothérapie. Et on a vraiment l'impression qu'il nous manque des facteurs prédictifs pour mieux sélectionner nos patients et pour pouvoir leur proposer la bonne stratégie au bon moment. Donc, sur cette session aujourd'hui, on va justement parler de l'apport de la biologie dans les cancers de vessie et des éventuels facteurs pronostiques, mais surtout prédictifs de la réponse au traitement. Je vous rappelle que vous pouvez poser vos questions via le chat. Alors, n'hésitez pas, on a la chance d'avoir de brillants orateurs aujourd'hui qui vont pouvoir répondre à la fin de cette session à vos questions. Donc, n'hésitez pas à nous les faire remonter. Et pour commencer, je vais laisser la parole à Tom Powles qui va nous faire un focus sur les facteurs prédictifs de sensibilité au traitement dans le contexte des immunothérapies. Thank you, Tom Powles, for being with us today. You can
Thank you. Thank you for inviting me. Listen, it's really sad that I'm not with you in what was a meeting that I look forward to and was looking forward to very much indeed. I'm really keen to take lots of questions at the end. I've got a lot of slides. I'll see how I get on. I've got a lot of conflicts of interest. The story of PDL1 expression and immune therapy in bladder cancer is complicated predominantly because we overcomplicated it as humans. So we devised 5 different programs. In each of those programs, we had immune staining and we had tumor staining. We used 5 different antibodies, all of which were different from one another. And then we use different cut points of how we define positivity. Essentially, what that means is there are an infinite number of definitions of PDL1 positivity. We now know that actually they're not all the same, and the experiments therefore are very different, and it makes things very confused. These are a summary of the 5 programs. I'm not going to go through them in detail, but I am going to talk a little bit about the consequences of what we did and why we did it. Essentially, you will be aware in bladder cancer that some of these drug trials, randomized phase 3s, are positive and some of them are negative. Some people come to me and say that must mean nivolumab is better than durvalumab. And actually that's not the case. What we've shown in these trials is the drugs are not as active as we hoped they would be. And so when we devised the trials, we were looking for hazard ratios of 0.6 or early 0.7. And in fact, the results came out in the early 0.8s. And what that means is some of the trials by luck are positive and some of the trials by luck are negative. And on top of that, if you put a biomarker, which we know nothing about, in reality, when we designed the trials, it turns out we knew nothing about the biomarkers. If you put biomarkers into the trials, then you're just introducing luck into the experiment. Albert Einstein was undoubtedly a genius, but I never understood this phrase. Insanity is doing the same thing over and expecting different results. But actually, we do the same thing over and get different results all the time. When Manchester United play Paris Saint-Germain, if the result was always the same, we wouldn't watch the game. Probability means that when we do the same thing over and the benefits are marginal, you get different results. This is a very important concept in clinical trials, which is something which I wasn't familiar with when I started my journey in clinical trials. Randomized phase 3s are not always the truth, because if the results are marginal, there's a 50% chance it's going to be positive and a 50% chance it's going to be negative. In my opinion, these drugs have more similarities than differences, number one. And number two is the biomarker simply confuses the issue. So this is the pembrolizumab randomized phase 3. This is second-line pembrolizumab versus dealer's choice chemotherapy in platinum refractory disease. I know it's an old study now, and we know it's positive in the ITT population, 0.73. And then in the biomarker positive, there is some enrichment. But notice it's also prognostic, because both of these curves, the median progression-free survival is shorter, particularly in the control arm. The PD-L1 biomarker, the 22C3 biomarker, is prognostic, and it's particularly effective for chemotherapy. It's actually not very predictive for immune therapy at all, even in this trial, because the difference is not the chemotherapy, the difference is not the immune therapy arm, it's the chemotherapy patients doing less well. So when we look at prognostic biomarkers, we always look at the immune therapy, but actually the same as in kidney cancer. The PD-L1 expression, the biomarker, the immune therapy arm is doing about the same. It's the chemotherapy that's doing much worse in the PD-L1 positive population. Predictive biomarkers are extremely complicated, particularly if you're not going against placebo. If you go against placebo, predictive biomarkers are easy. If you're going against an active control arm, you're always going to have the active control arm is going to have its own group of biomarkers. So that's the second important message. Message one, repeat the same experiment. You will get different results if the results are marginal. Message number two, if you have an active control arm, predictive biomarkers are extremely complicated because the control arm will have its own biomarkers. It's only placebo trials which work that way. This is the atezolizumab program. The atezolizumab program, identical population, cisplatin refractory disease, atezolizumab dealer's choice chemotherapy. We chose the biomarker based off single arm trials. You can see here the biomarker positive population doing better than the biomarker negative population in the phase 1 and the phase 2. This is perhaps the biggest mistake of my career, because we then went on to the randomized phase 3 and we showed the biomarker was actually much more powerfully predictive for chemotherapy than it was for immune therapy. So it picked the winners in both groups. I'm putting a random picture here of the Champs-Élysées, because, the Arc de Triomphe, because I miss being in Paris so much. So throughout my talk, there are going to be various French photos of my trips on holidays. The reason I put it here is just to emphasize, as with the cars going around the roundabout, there are so many infinite number of possibilities with these biomarkers that we need to put them to one side, because this is the atezolizumab PD-L1 biomarker in the frontline setting. You can see here in the biomarker positive patients, you can see some curves going apart with chemotherapy. They look a bit predictive in the biomarker positive population on the right-hand side here, and the negative you can see here, hazard ratio 1.07. So now we're beginning, the same biomarker, by the way, that wasn't working second line, appears to be working frontline. Why would that be the case? Well, it might be to do with a different chemotherapy. That's possible. But then look at the bottom here with adjuvant atezolizumab. And you can see the biomarker's not working at all. So when I said the biomarker was different between different drugs and different different settings, here, even the same drug with the same biomarker is behaving completely differently in metastatic disease, frontline, second line, and adjuvant disease. The conclusion of this has to be that this story isn't working as it currently stands. And we probably need to move on from the PD-L1 biomarker. This is the best trial we have, in my opinion, Avelumab versus best supportive care, because this doesn't have an active control arm, and there's been a lot of biomarker work generated from this. And what this is looked at is it's picked apart the TC component and the IC component, and you can see the TC component is more prognostic, but also more predictive. So the TC component, more predictive, the IC component associated with better outcomes. This is probably the best data we have to try and explain all of the craziness we've seen so far. The 211 data has, so this is a second line trial, and we've looked at other markers beyond PD-L1. Why have we done this? Well, everyone deep down knows PD-L1's not working. It's our dirty secret in the biomarker world. We know we need to move on. TMB, tumor mutational burden, a surrogate marker of tumor complexity. Actually, in retrospective analysis, only ever retrospective analysis, consistently looks quite good. The problem is that we pick different cut points again, and there are different ways of measuring TMB. Not until we unified these methods can we really confidently, prospectively do trials with this. We've not done this in bladder cancer. We've also looked at DDR signatures. So these are DNA damage repair signatures. They were made famous by PARP inhibition, but actually there is some data to suggest, single arm data, to suggest DDR signatures are good too. What I can tell you is that the randomized prospective data does not show DDR is attractive either. Having said that, tumor mutational burden actually has a label, pembrolizumab has a label in high TMB patients. It's my opinion that we shouldn't be using this. This is in all comers. We shouldn't be using this in urothelial cancer. TMB is not currently a strong enough biomarker, in my opinion. And again, coming back to that Javelin trial against placebo. So this is probably the most accurate data we're going to come across. And this is probably the most comprehensive slide we have. Avelumab versus best supportive care. Avelumab doing better in TMB high. That's the blue versus the dark red. And you can see TMB making no difference. Right now, would I do a prospective study with TMB as an endpoint in metastatic disease rather than PD-L1? The answer to that question is yes, I would. It's not perfect, but it's probably better than PD-L1. Don't focus on this too much, but other tumor types have been looking at circulating TMB. So we can also look at circulating TMB. So it's a more easily applicable biomarker. And so I feel that perhaps this is where we should be going from a urothelial cancer perspective, circulating biomarkers and circulating TMB. There's been a lot of work on gene expression analysis using RNA sequencing. This was a nice piece of work in Science, which prompted a lot of that work. And essentially, from here, you can see urothelial cancer about 5 down. TMB is TMB. GEP is a gene expression profile, a high gene expression profile. And what you can see from this is this gene expression profile across different tumor groups looks attractive. Again, if you come to that Avelumab trial against best supportive care, Avelumab best supportive care, you can see the Javelin. This is 2 gene signatures. Both appear to be predictive. Both have been previously tested in other areas and now validated in urothelial cancer. And so I put it to you, actually, because of PD-L1, we've got confused, but both TMB and gene expression profiles, both in my opinion, look more promising as it currently stands. Both look slightly predictive. I know there are shortcomings with gene expression profiles. I'd be very happy to answer any questions on that at the end. This is the last slide of that group. And this is really important because what this shows us is both innate and adaptive immunity are associated with response to avelumab versus chemotherapy. And you can see key components of innate immunity, natural killer cells, macrophages, dendritic cells, all playing a really important role. And it does make sense that actually there are multiple components of immune activated profiles associated with response to immune checkpoint inhibitors. And our original hypothesis of measuring one biomarker, which would answer all of the questions, was probably a bit naive with hindsight, and I'm partly responsible for that. This is a beautiful photo of me skiing last year. I just wanted to include it, I apologize. Okay, so the next piece, which is really important, is there are markers beyond immune biomarkers which are responsible for resistance. We've known for some time about TGF-beta, but now we can bring angiogenic signatures into that as well. So you've got complex immune activated pathways of the adaptive and the innate immune system. We also now have inhibitory stromal, myeloid, and angiogenic signatures. And this really is a three-dimensional balance between activation and inhibition going on in the tumors, which is why we're finding it difficult to find these prospective biomarkers. This here is the TGF-beta data, which was published in Nature a couple of years ago. All the TGF-beta work, by the way, has been done in urothelial cancer. Urothelial cancer is going as quickly as lung cancer in biomarker development. It's one of the areas which has been a real success, in my opinion. I'm going to move to my second part of the talk to non-metastatic disease. So we're going to talk about non-muscle invasive disease. As you know, neoadjuvant chemotherapy is a standard of care, but so is surgery alone. Whether you agree with that or not is a discussion for a different day, but that's the reality of how the world's currently working. Abacus and Pure 1 were neoadjuvant trials giving 2 or 3 cycles of atezolizumab or pembrolizumab, respectively. And what we showed was the first really important finding was the CD8 inflamed signatures were much higher in non-muscle, in muscle invasive rather than metastatic disease. So we have more immune prime tumors, we have higher PD-L1 expression as well. And then we can also measure these TGE, these RNA gene expression T-active immune signatures. Granzyme B is activated T cells. And when you combine those two together, you can actually identify the real winners, which I think is super cool, because what you can do is you can really discriminate between response and resistance by looking at the quality of the gene expression and the quality of the T cells, and ignoring PD-L1 and ignoring TMB altogether. And here you can bring in other factors as well to really try and increase the specificity. Really complicated, TMB not working at all in the neoadjuvant setting. 2 potential reasons. Number 1, are we giving the immune therapy for long enough? This is only 2 cycles. Or number 2, when CD8 is so high, does CD8 trump PD-L1 in the neoadjuvant setting? And the answer to that question, in my opinion, is I actually don't know, but I think it might be. And then actually, you can look for mutations as well. And these are mutations associated with response and resistance. And notice here, you've got FGF3 and FGF4, but FGF3 particularly associated with response. This is really confusing because we always thought the FGF3, and Yohann will talk about this in a minute, around the relationship between TCGA analysis and FGF expression and response to immune therapy. It's beginning to say that even the FGF story is going to turn out to be complicated. And then the last piece of these sequential tissues is around the treated tumors. So far, I've talked exclusively about biomarkers associated with baseline tissue. This is biomarkers associated with the treated tissue. And you can see here that CD8, as I said, zooming up with therapy, but look how the CD8, the treated CD8 is associated with response. And also look at FAP going up, and FAP, which is a stromal surrogate marker, the stromal surrogate marker being associated with going up with therapy and being associated with resistance. So this is kind of proof of that principle that there's a dynamic reaction associated with acquired resistance, which is really important moving forward, because it means we are going to have to use circulating biomarkers if we want to identify these dynamic changes. This static biomarker approach is very 2020. 2030, we will be looking at dynamic biomarkers, in my opinion. There's been some work as well, looking particularly in the neoadjuvant setting with immune combinations. And just very quickly, I wanted to talk a little bit about tertiary lymphoid structures. This is the new flavor of the month, 2 pieces of work in Nature Medicine, where you actually look under the microscope and you can identify with a multiplex IHC, you can identify also these structures associated with immune response. So the tumor is not homogeneous. There are, like cities, when you fly over a country at night, you see traffic lights and other lights densely combined in the cities. The same is going on in tumor groups, is we're developing lymphoid structures which are fighting these tumors, which I think are going to be important for the future. The last piece of what I'm going to say is around circulating tumor DNA. This is an area of increasing interest. It's an area which we've been working on for a while in our group. And essentially what we're doing is we're tracking DNA, we're tracking mutations using whole exome sequencing. So we do germline material and the tumor. We find up to 16 exclusive mutations associated with the tumor. And then we use plasma samples to track those with time. And in urothelial cancer, we can show in the neoadjuvant setting, about 60% of patients express 2 or more mutations. And in the adjuvant setting, it's about 40%. And then if you measure these DNA mutations in the plasma, you can see they're expressed in the neoadjuvant setting in 60% of patients, and look at baseline, how they correlate with response and relapse. Quite powerful. Now, this work has been done before by a group in Denmark, so this is interesting but not novel. But then when you give atezolizumab, look, you can see the responders have a significant decrease, which is not occurring in the other 2 groups. And then when you perform cystectomy, if you have ctDNA measured after cystectomy, you have minimum residual disease. These patients go on and many of them relapse. This is becoming quite an accurate tool, or potentially an accurate tool. And the reason I say that, this is a beautiful French mountain, I apologize. The reason I say that is we went on and did a neoadjuvant trial. And in that neoadjuvant trial, we did circulating tumor DNA on 700 patients with atezolizumab or observation. Here you can see that the biomarker evaluable population performed very similarly to the intention to treat population. You can see that there was the biomarker evaluable population who were ctDNA positive, and it was about 40% were positive, basically more node positive as well at surgery. But this is important. Look how prognostic it is. ctDNA post-surgery, very prognostic. And if you have ctDNA positive post-surgery, your chances of relapsing is about 75% versus the negative population, which is only 20%. This is quite a useful investigation, probably. And then look at this. So this is important. Focus on the bottom curve for me, the blue and the red. These are the ctDNA positive patients. In those patients, if you give those patients atezolizumab, you reduce the risk of death by 40%. This is the curve on the right here. But look, the biomarker positive patients, really discriminatory, really predictive. But the biomarker negative patients, low risk of relapse and no real difference. So this looks to be relevant. On top of that, 20% of patients clear their ctDNA with atezolizumab, and those patients that clear their ctDNA do significantly better. So this is proof of hypothesis. And there is a link between ctDNA positivity and TMB. So if you're TMB high and ctDNA positive, your hazard ratio is lower than if you're TMB low. And that links the biology in with the clinical findings. And the same applies for PD-L1. I've talked about quite a lot. Some of it I think is confusing. And I think the place I started was with huge uncertainty around PD-L1. I talked about the atezolizumab program with all of the inconsistencies. I moved on from there to talk about tumor mutational burden and saying it looks promising but hasn't been tested properly. I then moved on to the gene expression signatures, which I was excited about, but actually I then showed both the innate and the adaptive immunity, as well as intrinsic markers associated with resistance, are important in making up this jigsaw of response. We moved on to the neoadjuvant setting where we showed the tumors were more immunogenic and had a higher response than expected. And I also showed dynamic changes to biomarkers, pointing to the importance of circulating biomarkers for the future. I then showed circulating tumor DNA in the neoadjuvant setting being associated with outcome. And then finally, I showed ctDNA being predictive of response to atezolizumab and selecting patients with high-risk disease in the future. I can see an environment in the near future where patients are having tumor-related TMB measured, perhaps PD-L1 and a gene signature, and having monitoring with circulating tumor DNA in the future. I have my last slide, which is Bordeaux Cathedral. I was here last year. You can do no better in life than a city in Bordeaux, and I look forward to going back very soon. Thank you very much for your attention.
Thank you very much. It's a real pleasure to listen to you and to share with you on this topic. I have a first question. It's about the dynamic process with this molecular data. We have seen that there is some variation during time, over time, but do you think that previous exposure to other treatments could modify the expression of these biomarkers and potentially modify the sensibility to immunotherapy? And do you think that we should perform systematically biopsies or ctDNA before each treatment line?
Géraldine, what a great question. I mean, what does medicine look like in 2050? And that's the question that we need to start thinking about in 2020. Does it look like it like now, where we are essentially treating patients blind, using historical tissue fished out of a tissue bank, with all of the inconsistencies of biomarkers that don't seem to work? I think the answer to that question is no. I think it looks different. And the question is, what does different look like? I think you're absolutely right. I think that chemotherapy does change biomarker expression. I showed you that 2 cycles of atezolizumab doubles your PD-L1 positivity rate. So chemotherapy is going to do the same thing. In fact, we've got some work to show that that's the case. So we're going to have to be using contemporary biomarkers. If we're going to do that, or better treatments where everyone's cured, like testis cancer, I don't see that in bladder cancer right now. So if we're not going to get better drugs, we're going to have to pick patients better. If we're going to pick patients better, then we're either going to have to get better at doing biopsies, because at the moment we're not doing them, or we're going to have to find circulating biomarkers. I've got to tell you, my work at the moment is suggesting that circulating biomarkers is my preference. And I think as that expands, I think that's where we will end up. And so a lot of my emotional energy is going into circulating rather than tumor-based biomarkers now. And I think the question you've asked is, what does it look like in 2020, in 2050? And it looks like monitoring, actively aggressive monitoring treatment. I see radiology having a much smaller role. I see circulating biomarkers having a much bigger role. And I can see personalized therapy based around that premise.
Okay, thank you very much. Je vais peut-être laisser la parole à Yves, qui a sans doute des questions très pertinentes aussi.
Thank you, Thomas. It was a great talk. Just maybe Laurence Albigest raised a very important question regarding also circulating tumor DNA. What's the role for circulating tumor DNA for you in the context of adjuvant treatment or maintenance treatment, even to select the patients?
So I think it's a really good question, because it's currently in its infancy. We've only presented that data a couple of weeks ago, and it was in a relatively small meeting. Well, not that's IOSMO is a big meeting, but it wasn't presented at ASCO as a plenary session or anything like that. So I think the community is going to need to digest that information. There are strengths and weaknesses of that information. There are multiple ways of measuring ctDNA. You can use an informed approach with tracked mutations, as I showed here. It's expensive and time consuming. You can use uninformed approaches with Foundation One can do that, and there are other platforms, Guardant's another platform. We don't know if the different technologies all work the same. And so at the moment, it only works with this technology. And it's exploratory data. It was predefined before we started. There was a statistical analysis plan associated with it. And we've done RNA work and all sorts to show the biology works, but it's not a prospective randomized trial with alpha allocation. And therefore the FDA and the EMA are unlikely to approve it. But what it does do, in my opinion, is it opens up an important chapter. And that chapter is moving away from blinded adjuvant therapy in urothelial cancer to a more informed approach. And common sense dictates, as it currently stands, that our current adjuvant approach to cancer medicine, where everyone gets treatment in the knowledge that 30% of them are going to be cured by surgery alone, doesn't make a lot of sense to me. So this approach is an important first chapter in a book that will be long and successful. Is it premature to routinely be doing Natera ctDNA now on patients? Yes, it is. From a European perspective, I don't think it should be approved. But if the BMS trial or another trial comes through and shows the same findings, we need to start taking that seriously. Because I'm doing a bladder cancer clinic right now where there are 10 patients coming through. They've all had adjuvant therapy. 6 of them probably don't need it. You might be on mute.
Thank you. Thanks, Rob. Yes, we thank you. Thank you very much. It was very, very interesting. But we have to move on and maybe to let Yohann now present a talk regarding molecular classification in bladder cancer.
Thank you very much for inviting me.
Yeah, it was fantastic. Thank you.
I'll stay for Johann's talk, of course. Good luck, Yohann.
Yes.
Thank you.
Thank you, Tom. Hello.
Donc maintenant, je vais laisser la parole à Yohann Loriot, donc qui va nous présenter une mise au point sur la classification moléculaire et les facteurs pronostiques dans le cancer de vessie, et qui vont venir compléter donc les aspects d'immunothérapie qui ont été traités précédemment par Tom Powles.
Okay, so here in a picture from Paris for Tom, and good transition from Tom's presentation. So the field of molecular characterization of bladder cancer actually is moving very fast, and of course we did a lot of progress over the last 5 or 6 years. And maybe it is important to provide an update of what we learned and what questions we have to solve at short term, obviously. So overall, the underlying question for us as clinicians is, does it help for clinical practice and patient management in terms of prognosis, patient stratification, and target identification? So I will review what we know in early 2021 and what we learned in the past, and of course the perspective. And probably I'm not covering the biomarker of response to immunotherapy and so the immune environment, and Tom has already described that. So what we learned over the last 5 years, I think it's quite obvious that we did progress in the molecular characterization of bladder cancer and especially early stage. And first of all, the non-metastatic MIBC with the TCGA project. So to remind everyone, the main result of the study published in 2014 and then in 2008.
Merci.
So maybe it's my colleague here. So sorry. To remind everyone, so this was a comprehensive analysis of more than 400 muscle-invasive bladder cancer. And this sample has been characterized by multiple TCGA analytic platforms, and next generation sequencing help provide the wealth of molecular information needed for molecular classification of tumors from patients with bladder cancer. So MIBC was found to be one of the most frequently mutated human cancer, following lung and melanoma mutation rates. And chief among these mutations is the mutation of TERT, occurring with a frequency of 17 to 80% in patients with bladder cancer, but beyond TERT, occurring with a frequency of, beyond TERT, 58 genes were significantly mutated. And overall, the mutation load was associated with apobec signature mutagenesis. And importantly enough, clustering by mutation signature identified a high mutation subset with a very good prognosis at 5 years. Although the mRNA expression clustering refined prior clustering analysis and identified a poor survival neuronal subtype in which the majority of tumor lack small cell and neuroendocrine histology. So I will go back to this mRNA classification in a few minutes. So the identification of frequent mutation has in turn promoted novel therapeutic approach, as well as urine and blood surveillance implementation for both early detection and disease monitoring, as discussed by Tom. So we will see here some examples. So if I have to sum up, there was a lot of target based on DNA analysis that encompassed RAS and PI3 kinase pathway and cell cycle pathway as well. So for example, EGFR3 gene was found to be altered in around 50–20% of MIBC. And there was also a significant subset of tumor with PI3 kinase alteration. And other pathway encompass DNA damage response and epigenetic alteration. So when the data came out in 2014, we had a lot of hopes in terms of therapeutic options. So for some targets, we obtained encouraging data. I think the most significant result we have is the EGFR3 inhibition. In a phase 2 trial, we showed that erdafitinib, pan-EGFR inhibitors, result in an important overall response rate of 40% and median PFS of nearly 6 months and median overall survival of 11 months in platinum-treated patients. So as you know, erdafitinib is approved now in US, and the phase 3 trial, the Thor study, is still ongoing and aims to provide enough data for broader approval, and especially here in Europe. So erdafitinib is being combined with the PD-1 inhibitor, setrusumab, in first-line setting, and also in early stage in BCG resistance in MIBC. So the story is moving forward. But we also got a lot of failure. Here, 2 examples. And you are seeing here Petrogrivas at the bottom twice here. Don't think that Petros is associated with failure. He's doing a lot in bladder cancer. And you may know that is the last photo of the Javelin bladder trial published in New England last year. So having said that, as epigenetic alteration are very common in bladder cancer, mosetinostat, an histone deacetylase inhibitor, has been investigated in metastasis urothelial carcinoma with selecting epigenetic alteration. This was a failure with no response observed in this small study. Another example on the right side, DDR alteration. So there are some tumor with BRCA2 alteration, ATM alteration, CHEK2 alteration, and so on. So taking example from ovarian and breast cancer, PARP inhibitors have been investigated in metastatic urothelial carcinoma. And again, it is a good example of failure so far. No response was observed in the Atlas phase 2 study. Of course, other trials are still ongoing, but we are somehow nervous regarding the data. So since Tom is here with us today, Biscay, it was a very well-designed trial that combined immunotherapy and target therapy based on DNA analysis in second-line setting. So patients were treated according to DNA alteration, and multiple cohorts were offered to the patients: FGFR inhibitor, PARP inhibitor, and mTOR inhibitor, and the drug have been combined with durvalumab. But I have to say that it's quite disappointed. There is no clear signal for effective combinations, and the combination did well, but not enough compared to durvalumab alone. Sorry. So if I have to summarize, so far only FGFR3 inhibition has been successful so far. Androgenesis inhibition did not provide convincing data so far. HER2 combined with chemotherapy or given as maintenance were not very active strategies. So of course, there's other ongoing trials that investigate androgenesis inhibitors or HER2 inhibitor like the ADC, but overall, this is disappointing. So and why? And probably because we don't take into account for cancer complexity, meaning cell-cell interactions, mutation order, mutational process, and also the temporal heterogeneity may be an issue. So here an example. As I said before, the genetic alteration in epigenome are very frequent in bladder cancer, almost 2/3 of the MIBC. So our first look, without that, it would have been successful to target this pathway, but the approach we developed failed so far. So why? Cells in the normal urothyroids that line the bladder accumulate mutation caused by endogenous mutagenic process of APOBEC, for example, or by exogenous mutagens, so tobacco smoke. And some mutation in the chromatin modifying gene confer competitive advantage that drives cells to colonize larger regions of the urothelium, but additional mutations, so meaning the gene like TP53, PI3 kinase, FGFR3, and perhaps other change are needed to trigger malignant transformation. So suggesting that mutation in epigenetic gene are critical only in the early steps before cell transformation. So if we target this alteration too far during disease, it is not impactful for destroying the tumor cell, of course. Another example, the intra-patient mutational heterogeneity make it difficult. A chemotherapy-treated urothelial carcinoma is characterized by a high level of intra-patient mutational heterogeneity, and the majority of mutation are not shared between two different metastases or between primary and the metastasis. So of course, it is expected that the mechanism of resistance are more frequent in advanced disease because the tumor cells of heterogeneity. So it would be maybe more important to try to target this alteration in early stage in bladder cancer. So anyway, at least can we use this information to predict the response to the approved drug like chemotherapy? So if it is hard to find a good target in advanced disease, we can maybe use this molecular alteration for daily practice. So a lot of DNA investigation have shown that DNA damage and repair mutations identify cancers that are more chemosensitive. A tumor found to have DNA damage and repair mutation could identify the patient prospectively as having a chemosensitive cancer, so more likely to respond to either intravesical or systemic chemotherapy. And recently here, the group from the Aarhus University performed a comprehensive multi-omics analysis of 300 MIBC patients treated with chemotherapy in both neoadjuvant and first-line setting to identify molecular change associated with treatment response. And DNA-based associated with response converge on genomic instability driven by a high number of chromosomal alterations, signature 5 mutation or break2 mutation. So the molecular landscape may be helpful. So we need to validate on independent study like VESPER trial conducted by François and Yves, or prospectively, otherwise it's more complex, of course. So some trials have been conducted to confirm this encouraging data in neoadjuvant setting, for example. So beyond DNA alteration, we can analyze also gene expression. So the whole transcriptome mRNA profiling of tumor tissue sample from patients allow to establish a molecular taxonomy for bladder cancer. But we have to recognize that there is still some variation across molecular subtype classifications due to patient selection, methodology difference, and pathologic and clinical criteria. However, a consensus MIBC molecular classification was achieved by an international group led by Aurélie Camoun, Aurélien de Rennes, Yves, and François Radvani, and they came up with a single, simple classifier integrating 6 non-overlapping patient subtype, and which was also highly consistent with the previous classification studies. So just to remind that the consensus classification include a luminal papillary, a luminal non-specifying, luminal unstable, a stroma-rich, a basal, and a neuroendocrine-like subtype. So in this consensus classification, the luminal tumors show enriched urothelial differentiations, FGFR3 genetic alteration, and we can imagine to use this classification in daily practice. So having said that, we can envision try to perform a molecular-oriented therapeutic strategy. So as I said before, the luminary pupillary subtype is characterized by FGFR3 alteration. So third cancer have a low risk of progression, and preliminary data suggest that they have a low likelihood of response to cisplatin-based neoadjuvant chemotherapy. And the frequency of FGFR3 alteration in luminal papillary tumors suggests that the FGFR3 inhibitors may be an effective treatment approach, and especially since early clinical trials, so the BLC 2001 study, show benefit of erdafitinib in these patients. The luminal infiltrated subtype is characterized by median expression of PD-L1 and CTLA4 markers. And these subtypes has been reported to respond to immune checkpoint therapy with atezolizumab in patient marker. The basal subtype is characterized by higher incidence in women's squamous differentiation, basal expression, and high expression of PD-L1 and CTLA4 markers, and other signs of immune infiltration. And both cisplatin-based chemotherapy and immune checkpoint inhibitors may be appropriate therapeutic options for these patients. So the problem is that it's not clear how this classification may help. In a seminal paper, a seller from Peter Black team in Vancouver show how this molecular subtype can be used to identify patients who will benefit from chemotherapy. But while this study still needs prospective validation, the results are revealing that the cancer that are most appropriate for neoadjuvant chemotherapy, the basal-like cancer, are actually made more benign after chemotherapy. So I would say that, again, we have to validate this data with a new consensus classification, and VESPER, we hope that will do that in the coming months or years. So generally speaking, the first generation of precision medicine program provide some success in different tumors, and in urothelial carcinoma, we had a success, but overall it's not enough. And Tom discussed the biomarker of efficacy with immune checkpoint inhibitors, but it's still unclear, for example, whether or not TMB is a good biomarker in urothelial carcinoma. And why it's quite disappointed, there is many reasons to explain this result. And among them, one reason is that actually we don't know so much from genomics of metastasis. And as I said, we explore mainly early stage and archival sample from nephrectomy or cystectomy, but it's not really the metastasis. So that's why we try to study the molecular characteristic of metastasis from urothelial carcinoma. And this study is performed by a collaborative group from Gustave, Curie, and CIT. all the samples were collected from metastasis of patients enrolled in our program, and we enrolled nearly 100 patients and analyzed 114 patients. So we can see here the heat map with the main characteristic of the cohort. So if you have a good memory, you can see that the molecular landscape is quite similar to the TCGA cohort of 400 non-metastasis MIBC. The mutational burden is again very similar. And to obtain some insight into ongoing tumor evolution dynamics, we examined the clonality of all the variants, and few mutations across the cohort were found to be subclonal. So the low proportion of samples with subclonal variant could be due to detection limits of the sequencing approach, of course. But although the cohort contains some samples with high fraction of subclonal variant, overall the metastasis tumor samples are relatively homogeneous without the presence of multiple diverged major subclone. So on the right, you can see here that we found some alteration more frequent in metastasis, and especially FGFR3 mutations. Maybe I can move. If now we try to look at the pathway level, and not only the gene level, we found that similar alteration with alteration in chromatin regulation, cell cycle, genome integrity, and PI3 kinase pathway being the most frequent altered in metastasis. Another question, is there any difference between bladder and upper tract disease? And it seems that in metastasis setting, at least, there is no big difference between these two tumors. And finally, if we focus on druggable target, FGFR3 is the most frequent altered target. And then you can see also ARID1A, PI3 kinase, and HER2. What is very striking, I think, is the transcriptomic classification in metastasis. It seems that the neuroendocrine subtype is more frequent in metastasis, and there is a clear variability between the metastasis site. I think one important reason is that when we compare the temporal evolution with two lesions from the same patient on the right here, we observe some evolution. And also in the same sample, there is a huge heterogeneity of subtype. So over time, there is an evolution, making it more difficult to implement the value of subtyping classification in daily practice. And while it is quite clear that in TCGA, so in non-metastasis sample, each subtype is associated with clear features of microenvironment, it's not the case in metastasis, or it is less significant, making, again, more difficult to implement in daily practice. There is also another pan-cancer dataset, or whole genome sequencing of metastasis, and you can see here another example. And in line with previous studies on primary cancer, they found that extensive variation in the mutational load, up to 3 orders of magnitude both within and across cancer type, and bladder cancer is one of the most mutated cancer in metastasis setting. And an extreme form of copy numbers change can be caused by whole genome duplication in bladder cancer. Bladder cancer is, again, one of the most frequent cancer with whole genome duplication. So nearly 20% of metastasis urocellular cancer sample have a high mutational burden, and 3% had an MSI status in this cohort. So to gain insight into the overall genomic difference between primary and metastatic cancers, they compare the mutational burden in metastatic cohort with the pan-cancer analysis database. And in general, the mutational load does not seem to be indicative for disease progression. It is not significantly different in this study compared to the TCGA cohort. So it's very consistent with what we found in our cohort. So is there any specific molecular alteration metastasis? So they did some analysis for significantly mutated gene, and they overall reproduce previous results on cancer driver, identified a few novel genes that are potentially related to metastatic cancer. In bladder cancer, for example, rare gamma was found to be specific. SOX4 set out at a significantly amplifying single gene peak. and is highly enriched in bladder cancer in 20% of the sample. So the most prevalent driver gene in bladder cancer is consistent with previous studies. So at the per patient level, the mean number of total candidate driver gene in cancer in general is around 6, and it's a little bit higher in bladder cancer, around 8. So in almost whole sample, at least one somatic candidate driver mutations or germline variant was found. Although they analyze opportunities for biomarker-based treatment for all patients by mapping the driver events to clinical annotation database, and in 3/4, at least one predicted candidate actionable event was identified, so in line with results from primary tumor. So as a conclusion, first conclusion, we can say that individual metastatic lesions are relatively homogeneous, with the vast majority of driver mutation being clonal. Metastatic tumor exome show similar mutational landscape and driver gene to primary tumor. And genomic instability events are the more persistent element of tumor genesis than previously understood, and effective over the majority of bladder cancer. So to me, the single omics analysis have reached a plateau, and we need new approach to find new targets. The classification was not shown to be very useful in daily practice so far, and the molecular classification must take into account for cell dynamics and multi-parameters. So at least molecular screening may help for patient stratification. So a first example in metastasis setting, we discussed the interest and the impact of cell-free DNA. Here, an example from the Vancouver group. They showed that TMB, for example, was not clearly associated with response to CPI, but they showed that FGFR3 mutation was associated with lower response to CPI. And overall, the concordance between the tissue and the cell-free DNA was quite good. And we did the same analysis at Gustave Roussy. And the question here was, is cell-free DNA truly representative of molecular landscape in the tissue? And the response is probably yes. We look at this and show that at least for druggable targets, the sensitivity of cell-free DNA is quite high, and the overall concordance between cell-free DNA and tissue is quite good. So maybe I will move on this slide because some discussed the interest of cell-free DNA in adjuvant setting. So I will maybe pass this one. I think another point is also the germline variants. So the prevalence of biology consequence of germline variant in urothelial cancer is not very well characterized. And here is a team from Bischoff Faltas in New York performed whole exome sequencing of germline DNA and in some metastasis tumors, and developed some bioinformatics framework to identify putative germline variant. And they show again that urothelial carcinoma patients are born a high prevalence of germline variant that truncate tumor suppressive protein. So here's, I mean, it's some example to show that we have to move in terms of precision medicine. Molecular characterization of bladder cancer should move from DNA analysis to more complex characterization, taking into account for evolutionary concept, reactive genomes, phenotyping evolutions, using multiomics, functional assay, and new technology. So it is very important for studying prognosis, stratification, and of course, drug resistance. And it is even more important in the context of antibody drug conjugates that target protein expressed at the cell membrane. So we will have in the coming months or maybe years, enfortumab vedotin that is already approved in US and maybe in the coming months in Europe, since the phase 2 trial met its primary endpoint. We have also the sacituzumab govitecan that target TROP2, and the phase 2 trial show promising efficacy. So in this context, we will have to maybe characterize tumor on a molecular basis, of course, but also using more parameters with immunohistochemistry, spatial heterogeneity, and pathomics. So now moving to the early stage to the non-muscle invasive bladder cancer. We have some data, of course, and multiple studies have characterized DNA and RNA alteration in this stage. Deletion in chromosome 9, so harboring the CDKN2A gene, as well as mutation in FGFR3 and PI3 kinase, were identified as early events in urothelial cancer. So what is important to stress is that the high-grade T1 exhibit a molecular landscape very similar to that of MIBC. So maybe the strategy in terms of systemic therapy in MIBC may be similar between the two stages. And importantly enough, there are some data suggesting that some gene alterations are associated with lower response to BCG. Alteration in FGFR3 and the epigenic gene CREBP are associated with a higher risk of recurrence, but did not reach a significant p-value in this study. And the only one gene that was clearly associated with a risk of recurrence after BCG was ARID1A mutation. And this is very interesting because this is a gene that encodes a member of Swiss NIF family, and we know that there is a strong interaction between epigenome and immune system. And more recently, a study focused on these T1 high-grade tumors and the association of simulating mutation profile with non-recurrent disease, recurrence or progression sample was performed. Tumor mutation burden was similar to muscle-invasive bladder cancer and was highest in patients with good outcome and lowest in patients with recurrence. So DNA damage response gene mutations were associated with higher TMB and good outcome. RSCC2 and BRCA2 mutations were associated with good outcome. So the overall results mean that we can imagine we can select patients for which BCG may be active based on this molecular data, so TMB and alteration in DNA repair gene. And finally, so we try to assess the T1 high-grade tumor based on mRNA again, and the most significant study in this field was reported 5 years ago, the UROMOL study, that performed a comprehensive transcriptome analysis, including around 500 patients with early stage NMIBC. And there was different class of, based on mRNA. The class 1 tumors show enrichment in early cell cycle gene and are associated with good prognosis. Class 2 tumors exhibit high expression of late cell cycle gene, and the class 3 tumors were enriched in basal markers. So the class 2 tumor are associated with lower rate of survival compared to class 1 or class 3 tumors. And the class 2 tumors highlight the similarity again between MIBC and high-risk non-muscle invasive bladder cancer. So coming back to the central question, does it matter? I think it's the most important question we have. So the pros would say yes, because based on what we know from MIBC, we may predict therapeutic benefit of chemotherapy, predict benefit from and expand the impact of immune checkpoint blockade, and we may identify new therapeutic targets for resistant disease. But some, and maybe, I guess, a lot of clinicians would say no, because unfortunately, the information from TCGA based on data for MIBC, the majority of the data on MIBC is from low-grade tumor. There are limited data on high-grade tumor and epigenetics, and there is a lack of reliable genomic predictor for recurrence and progression in early-stage disease. So as a conclusion, we did a significant progress in the understanding of molecular interaction in bladder cancer, but few biomarkers had reached clinical utility so far. Cell-free DNA in blood and urine may be impactful. We need prospective validation. Is it will be even more complicated in the futures, and we need deep phenotyping cohort to understand the cancer complexity. And here, an example, the major goal in the future will be to try to gather the genomic, transcriptomic, and proteomic classification into unified classification and to increase the feasibility of gathering the needed data from each patient for clinician to make the most important and informed choice. So here it's an ongoing project where the link between genomics and microenvironment is assessed. Patient candidate for immunotherapy and undergo biopsy baseline, on treatment and at resistance, and multi-omics analysis are performed, integrated in whole exome sequencing, single-cell RNA sequencing, bulk RNA sequencing, and multiplex immunohistochemistry. So finally, I have to mention all people involved in the work on bladder cancer that we are doing, so Yves, Maud Kamal, François, Yves, and of course the bioinformatician, Lorraine, Celia, Remy, and Nawal. Thank you.
Thank you, Yohann, for your talk and raising all the problems, in fact, that we have from going from the molecular data to the use for the patients. And we are a bit late, but maybe I want to tell you about one question raised by Tom, which is a conceptual question. He says he asked, in fact, whether the TCGA analysis, which seems to be an ongoing and increasingly complex process. So for you, is it a step to personalized therapy or more an interesting biological experiment? This is the big question.
Yeah, I think it's more for the science because the data we got from this analysis showed that the bladder cancer, like other solid tumors, are very complex actually, and so I think this analysis provides some insight into the biology, and maybe we can identify more, I would say, more targets for therapeutic. But for molecular stratification, I think it's even more complex, and I'm quite anxious and nervous how we can implement the for example, the consensus classification in daily practice, because of the heterogeneity. We discussed that with Tom earlier. There is a clear evolution between two different metastases or two lesions within the same patient. There is obviously technical issue to reproduce the classification. So to me, we are far away from the daily practice implementation of this analysis, but it's still very important for a better understanding of the biology and to find more targets for our patient.
Yeah, and very quick answer to a question raised by Virginie about the interest to use immunohistochemistry, in fact, in practice to implement molecular classification. But I think you answered to that. It's too early.
I think it's too early, clearly too early. We have to prove that the classification is helpful, and we did not do this this work so far. So it's too early.
Yeah, and so now we have to think about how to use this molecular data in our future clinical trial in the cooperative group.
Of course.
So thank you.
Je crois qu'il n'y a pas d'autres questions sur le chat, donc on va pouvoir effectivement clore cette session vessie. Je remercie à nouveau les orateurs Yohann et Tom Powles. Je remercie également tous nos partenaires et je vous rappelle que pendant la pause déjeuner, qui sera donc jusqu'à 14h, vous pouvez aller sur leur espace partenaire pour aller les visiter, hein, même si on est en virtuel. Et puis on se retrouve à 14h. Je vais peut-être laisser la parole à Karim pour le mot de la fin.
Je crois que tu as tout dit, Géraldine. Un grand merci aux deux orateurs et à vous deux. Et un bon appétit à tout le monde. On se retrouve à 14h pour une jolie session aussi sur les premières lignes métastatiques dans le cancer du rein et de la prostate. Et d'ici là, très bon appétit. Un big thank you, a very special thank you to Tom. Really, we were delighted to have you today. Thanks a lot, Tom.
See you soon.
All right.